I'm staying, he's leaving.
Okay.
Yes, while Marin Klein's coming up to the CDC funding that was just mentioned goes through 2019, so that's the time frame for that.
Excellent, thank you. Issue 14.
Well, good morning again.
Afternoon.
Is it afternoon already? You all know who I am. I also have with me Marin Klein, our assistant deputy. My day job is the deputy director for environmental health in Department of Public Health. And a little bit about our center, and then we'll jump into the proposals. The Center for Environmental Health works to protect the health of Californians by conducting environmental management activities. These are things like the marine biotoxin program. You've heard about domoic acid in crabs and the things that happened to the Dungeness crab season this year. We manage medical waste management and a number of other things. Also in our center, we oversee the use of radiation, and this includes all medical uses, both diagnostic and therapeutic, as well as commercial uses and research uses of radiation. And then lastly, the main area and the most relevant for us today is that we ensure the safety of foods, drugs, and medical devices in our center. Because of this expertise in the oversight and the safe processing and manufacturing of foods, as well as because of our laboratories that support this work, the new Medical Marijuana Regulation and Safety Act specifies that CDPH oversee both the manufacturing and the laboratory testing of medical marijuana. However, this new commodity is neither a food nor a drug, and the medical marijuana industry is certainly new to our department. So we are establishing a new program and new structures to successfully carry out our role. The agenda write-up was again excellent, and Marin Klein will present an overview of the proposal and will address your specific questions.
Good afternoon. My name is Marin Klein. I'm the Assistant Deputy Director for the Center for Environmental Health. What I'm going to do first is give a quick overview, summary of the proposal. Just to bring you up to speed in the history of the medical marijuana program, last year the governor signed 3 bills, AB 266, AB 243, and SB 643. And those established the Medical Marijuana Regulation and Safety Act. This is a new law and provides a statewide regulatory and licensing structure for medical marijuana. There are 3 main departments identified as licensing authorities in the new law: the Department of Consumer Affairs, Department of Food and Agriculture, and the Department of Public Health. The Department of Consumer Affairs will establish the Bureau of Medical Marijuana Regulation, and they are the lead program in the implementation of the new law. The Bureau will be responsible for licensing the distributors, the transporters, and the dispensaries. The Department of Food and Ag will be responsible for licensing the different types of cultivators. And then Public Health, we are going to be responsible for licensing the manufacturers and the testing laboratories. There are also a number of other agencies that have a role in the regulation of marijuana, such as Fish and Wildlife, Department of Pesticide Regulation, Water Board, Department of Justice, and Board of Equalization. The budget change proposal request that we have in front of you is for authority and funding for public health to develop the regulations, standards, the enforcement, and procedures for licensing the medical cannabis product manufacturers and testing laboratories. We will, of course, be coordinating with the Bureau, with Food and Ag, and others to ensure coordination of regulations, licensing, and enforcement activities. So we're requesting a total of 37 positions, and we're going to phase these in starting in January of this year through 2018. This is, at this point, our best current guess or assumption. So for fiscal year 15-16, we have requested 6 positions and $457,000 in reimbursement authority, and this is through a contract with Consumer Affairs, who received the appropriation from the bill. For 16-17, additional 8 positions and $3.4 million, and this will be an appropriation directly to the department from the newly established Medical Marijuana Regulation and Safety Act Fund. For fiscal year 18-19, 2 additional positions and a budget of $2.5 million. And then for fiscal year 19-20, 21 additional position and an ongoing appropriation of $5.6 million. All of this funding will be in the form of loans that we will repay back over time from the collection of the fees. Unless there's any questions about the overview, I'd like to move on to question number 2.
Perfect.
So the, question number 2 is asking about the timely development of regulations. So let me assure you that regulations are our highest priority task with this new program. We have already began the development process by researching regulations that other states have adopted, also researching FDA regulations when it comes to good food and food manufacturing practices to identify what will work for our program. We have been meeting with stakeholders. We have also been touring facilities to better understand the industry and their current practices. We are closely coordinating and collaborating with the other departments, such as the new Bureau, Food and Ag, as we move forward to develop the regulations. We are currently hiring the additional staff that we need to develop the regulations, and our expectation is to start issuing the licenses in January of 2018, which is the mandate in the new law. If you don't, unless you have any questions for number 2, we can move on to question number 3, and I will turn it over to Dr. Starr for the surveillance question.
I have a long background in epidemiology and surveillance, so that's why I get to handle this one. So we appreciate the question about a public health surveillance system, and surveillance systems are a critical component of public health. Our department has experience with surveillance systems in many programs. You heard this morning about infectious diseases, communicable disease reporting. We mentioned earlier a little bit about the cancer registry and cancer reporting. We have population-based surveys to assess behaviors that are related to health and other potential contributors to ill health. We also do injury surveillance, and in this area we use poison control center data, we use hospitalization data, emergency room visits, and we also use death certificate data for some of these activities. So we utilize surveillance in public health for a number of purposes, certainly identifying health problems, and whether it's new diseases or new health negative habits. We target public health resources to areas based on surveillance, and we also monitor programs using surveillance information. So as we implement the medical marijuana regulations and licensing procedures, we should gain a better understanding of the industry. As I mentioned, it's a new industry to us. We'll be better able to determine what might be appropriate surveillance strategies to assure the quality of this new regulatory system. And last, I just want to add that this public health surveillance system topic will impact all 3 of the main licensing programs, the Department of Consumer Affairs, Department of Food and Ag, and our department. And we certainly would like to include them in this discussion about surveillance as well.
Thank you. In developing a health surveillance system, what would be the oversight of traffic accidents, vehicle-related accidents attributed to intoxication from medical marijuana?
So there's, I don't know the details of the data, but we get that data from law enforcement entities for impaired driving. And so that is a potential addition to the ones that I mentioned as a source of information. At this point, I don't know if we know how law enforcement will track those events and attribute them to marijuana.
Right, I know that's been one of the challenges, is just how does that monitoring take place by law enforcement in terms of determining causal connection between potentially medical marijuana and aberrant driving behavior leading to accidents. Do you know if Colorado's doing what Colorado's doing in terms of that, or other states that have?
We've looked at other states and how they're looking at the public health impacts and surveillance a little bit, but I don't know specifically about impaired driving.
Right. I would encourage that that be part of the matrix, because I think it's, I know, a concern of many, and we're on the precipice of possible legalization of recreational use as well. And so I think much of what's being developed here for medical marijuana will have a utility and application should there be a broader legalization. Thank you.
Thank you, Madam Chair, members. Meredith Worden with the LAO. Our office released last month an overview of all of the budget proposals related to this new legislation, and so it summarizes across the 6 departments the requests in the current year, budget year, and ongoing. Overall, we found that the proposed approach is consistent with the legislation and did not identify any major concerns, although we do note that ongoing oversight will be important. The scope and the complexity of these new activities is significant. And as such, legislative monitoring of the overall status and pace and effectiveness of the new legislation and implementation will be important in the coming years. We also highlight a few additional considerations for the legislature, including that implementation will require a considerable amount of cross-departmental coordination, including for public health, such as with the Department of Food and Ag and Consumer Affairs in coordinating the development of regulations, fee structures, and an IT system to track marijuana production from seed to sale. Also, it will require a substantial amount of coordination with locals. We find that ongoing regulatory costs are still unclear. And that timely implementation of this new legislation and related regulatory requirements will be a challenge. As noted, it's expected that it will be stood up by January of 2018. That is rather quick. And then we also finally note that there are other factors that could change the landscape, including voter expansion of legalized marijuana and potential changes in federal policy. Thank you.
Thank you. Finance? Any public comment? Seeing none. We'll move on to issue 15, the End of Life Option Act, AB 15X2, 2015. You got it. What's your name?
Good afternoon, Madam Chairman and Senate Committee. I am Tony Agurdo. I'm the Assistant Deputy Director for the Center for Health Statistics and Informatics. And so the overview's already been provided there before you. And so what I'm going to do is just give you a summary of what it is that we're requesting. And so that to implement the End-of-Life Option Act, Department is requesting $323,000 from Health Statistics Special Fund. And so that's a fee-based fund. For 2016-17, $245,000 in 17-18. And thereafter. We're also looking at 2 positions, they're permanent positions. One is an AGPA, one is a research scientist, and to help to both implement and to continue the requirements of the End-of-Life Option Act. The other part of this funding is going to be used to develop a secure database to implement and administer this program, because this is a very sensitive issue, and so that we have to ensure the protection of the identity of those individuals that may be involved.
Any questions or comments from LAO Finance members? Why don't we move on? I know that you're going to present on the following two issues also, issues 16 and 17, and I'll hold public comment until the end of the presentation of issue 17. Fair enough?
Okay, yes, and I'll just go ahead and go right through both of them.
Perfect.
And then, again, the summary is excellent. So issue 16 is the collection of data of multi-race and multi-ethnic origin. Up until now, we have been collecting data on 3 races. And so that because this may not provide a clear picture of the public, we are going to ask for voluntary self-identification of multi-race, multi-ethnicity. And we're asking for $236,000 in fiscal year 2016-17, $234,000 for fiscal year 2017-18. And we are asking for 2 positions that will be redirected from vacancies already existing within the department, so that those will not be new positions. Okay. Moving on to issue 17. This is the Gay, Lesbian, Bisexual, Transgender Disparities Reduction Act. And this, again, is asking for voluntary self-identification to identify or to see where the disparities are in terms of the provision of health and public health. The expenditure we're asking for is increased authority of $125,000, again from the Health Statistics Special Fund, which is fee-based. And this is to modify the current birth and fetal death system, as well as the looking at another system that we call the AVA system, which is it's the birth system. So this fund will be used to adequately improve those systems to collect this data and then disperse the data as needed.
I have a quick question.
Of course.
So the data will be collected via what sources?
The whole purpose of vital records itself is to both collect vital events and then issue certified copies of those vital events. On those documents, information is collected regarding whether it's a birth, death, or marriage, or fetal death. And so that this is a voluntary disclosure of information. So there will be additional, if it's not collected already, files or check boxes that a person can self-disclose. That information will be gathered, tabulated, and then also we're looking at, depending on how much information is collected and where it's coming from, there might be small size suppression in the sense that we don't want people to be identified necessarily, so that's going to be taken into consideration to protect that, those people. So the sources are the
Vital records.
Those vital records.
So on a birth certificate, who would be identifying? The parents?
The parents identify on those, and yeah,
Okay.
we don't know what the,
That's right. Okay, that's why I thought this is the unique circumstance. Maybe there are additional records that you'd be collecting, but it's the standard ones you just
it's the
reviewed.
standard things.
Got it. Okay, thank you. LAO, Finance, Senator Monning. Any public comment on issue items 15, 16, or 17? Seeing none, we'll hold the items open.
Thank you very much.
Thank you very much. Moving on to our final 2 issues for today, issue 18, Office of AIDS, the AIDS Drug Assistance Program, ADAP, which will be followed by increased access to HIV pre-exposure prophylaxis PrEP. Yes.
Good afternoon.
Good afternoon.
Nothing like being between everyone and lunch. So I'm Dr. Karen Mark.
Be really efficient.
Yeah. I'm Dr. Karen Mark, Chief of the Office of AIDS at the California Department of Public Health. So many thanks to the Senate staff for providing a wonderful summary. I'll try and be efficient. The Office of AIDS is responsible for all of CDPH's HIV surveillance activities, keeping track of the number and demographics of the approximately 5,000 Californians who are newly diagnosed with HIV every year, 140,000 Californians living with the disease, and about 1,400 HIV-infected Californians who die every year. We are also responsible for all of the prevention and medical care and support services that are funded through the department, as well as the AIDS Drug Assistance Program, or ADAP. So I'll present the ADAP estimate first, and then move on to the budget change proposal. To give an overview, the 2015 Budget Act included ADAP local assistance funding of $396.6 million with no state general fund appropriation. The revised 2015-16 budget is $317.1 million, a decrease of $79.4 million, mainly due to ADAP clients continuing to transition from ADAP to Medi-Cal, or HIV-infected clients enrolling directly in Medi-Cal instead of ADAP. ADAP clients are also continuing to transition to private insurance through Covered California. The revised current year budget does not contain a general fund appropriation or any cuts to services. Because the previous Medi-Cal 1115 waiver expired on October 31st, 2015, Safety Net Care Pool reimbursement funds are no longer available to ADAP. In fiscal year 16-17, the proposed ADAP local assistance funding is $330.2 million. OA estimates that expenditures will decrease by $66.4 million when compared with the Budget Act, but increase by $13.1 million compared with the revised current year. The increase of $13.1 million compared with the revised current year is primarily due to new clients enrolling in ADAP. Clients will continue to transition from ADAP paying the full cost of their medications to Covered California and Medi-Cal expansion in 16-17, but we expect that the number of clients leaving or changing client groups will stabilize and that client caseloads will again increase due to people being newly diagnosed with HIV. So as always, we'll update those numbers and then may revise. You had also asked for an update on the transition of ADAP clients to Medi-Cal and Covered California. So every autumn during the past 3 years, we send a letter to all ADAP clients who are potentially eligible for either Medi-Cal expansion or Covered California with information about both programs and application instructions. We also develop and annually update a flow chart for enrollment workers outlining which ADAP clients should be referred to which program. All new ADAP clients and ADAP clients coming in for their annual recertification, which occurs during their birth month, are screened and directed towards the appropriate program. We create and annually update a comprehensive healthcare coverage fact sheet that enrollment workers must review with clients who are potentially eligible to purchase insurance through Covered California. During the enrollment or recertification visit, these clients are informed verbally and in writing that they can seek premium payment assistance through our Office of AIDS Health Insurance Premium Payment, or OAHIP program, and can enroll or remain co-enrolled in ADAP for assistance with their drug copays and deductibles for drugs that are on the ADAP formulary. But the clients are currently responsible for medical out-of-pocket costs. They're also informed that we'll start covering allowable medical out-of-pocket costs by mid-2016 and about federal financial penalties for remaining uninsured. Enrollment workers must check and initial this fact sheet, acknowledging that they have reviewed the information with the client and have the client sign and date the fact sheet and maintain a signed copy in the file. These procedures are designed to be in compliance with Federal Health Resources and Services Administration directive that we vigorously pursue enrollment in healthcare coverage for which our clients are eligible, and we also think it's really important to just educate our clients about all of these opportunities. ADAP created and annually updates a comparison chart that compares the HIV and hepatitis C drugs, which are on ADAP's formulary, with those covered by the various Covered California Health Plan formularies to assist clients with picking a plan. It's located on our website. And we also created a quick reference guide for covered California agents, navigators, and call center staff. The goal of the document is to provide an overview of ADAP so that covered California staff can better assist current or potential ADAP clients with enrolling in covered California. The document also conveys how critical it is for ADAP clients to have continuous access to medical care for their medications. And this Covered California has made this document available on their website. So any questions?
Question. We started today hearing a report from the Office of Patient Advocate, and that's what triggered for me. If a ADAP client had a complaint with regard to their experience in their transition from ADAP either to Medi-Cal or Covered California, who would they file that with? ADAP or Office of Patient Advocate?
Well, we do have
My question really is, like, where are we tracking? You give us the data in terms of the transition. There was, some tension we've heard in this committee over the last couple of years about the reality of this population being transitioned over to Covered California. So I'm curious as to what their experience has been and who would know.
Well, we do in ADAP have a formal grievance process, so people can submit that. We track that and work to resolve all of those issues. If the issue is specifically with a program outside of our jurisdiction, like Medi-Cal or Covered California, then that would go through whatever mechanisms they have. But we generally try to work very closely with our clients and with our partners in DHCS and Covered California to really make sure that the needs of our clients are met. That's part of our public health orientation, making sure that they're getting the medications that they need.
Got it. Thank you.
And then you had also wanted an update on the implementation of the trailer bill language related to medical out-of-pocket costs. So on September 4th, 2015, we released one request for proposals, or RFP, for both insurance benefits manager and medical benefits manager services to pay insurance premiums and medical out-of-pocket costs, respectively. We awarded these agreements to on January 5th of this year to Pool Administrators Incorporated. The contract was executed yesterday, and we are currently working with the contractor on implementing these programs with the goal of providing services in the spring of this year. Any questions about that before I move on to PrEP?
Go on to the next issue number 19, please.
Okay.
On PrEP.
So HIV pre-exposure prophylaxis, or PrEP, is a new federal Food and Drug Administration approved prevention tool for people at high risk for HIV acquisition that involves taking one pill every day. The single pill contains 2 HIV medications within it. Taken daily, PrEP medication can reduce HIV acquisition by over 90%. Prior to its use as an HIV prevention modality by those who are HIV negative, the same medications have been used by those who are HIV infected to treat HIV for over 10 years. At the end of 2013, there were about 121,000 persons living and diagnosed with HIV in California and reported to the Office of AIDS. However, CDC estimates that about 11% of people living with HIV in California are unaware of their infection. While California has made significant progress in identifying people who are unaware of their infection, the state has been only minimally successful in reducing the annual number of new HIV infections. From about 5,169 in 2000 to 4,712 in 2013. So over 70% of these new infections are among men who have sex with men. As a result, a new effective HIV prevention modalities are really desperately needed, including PrEP. To implement PrEP in California, on September 3rd, 2015, CDPH was awarded $3.5 million from the Centers for Disease Control and Prevention to fund 4 California metropolitan statistical areas determined by the CDC. In order of HIV prevalence, these are San Diego, Orange, Alameda, and Riverside counties. The funding is designed to facilitate broader awareness, support, and capacity for the scale-up of PrEP services and address barriers for men who have sex with men and transgender persons at high risk for HIV infection, particularly people of color. Nationally, only 12 jurisdictions receive this competitive PrEP funding, including 3 in California, the California Department of Public Health, as well as direct funding to Los Angeles and San Francisco. CDPH requests federal fund budgetary authority to expand $2.625 million in 15-16 and $3.5 million in 16-17, and requests the addition of 5 permanent positions to implement this grant. Prep activities include administering the funding at the state level and determining in consultation with the local health jurisdictions the most effective levels of funding. CDC requires the use of these demonstration project funds to develop and provide training and technical assistance for navigation and outreach services, and to develop and distribute educational resources for clinical and non-clinical providers, as well as local health department staff and community-based staff, as well as for consumers or patients. Any questions on that?
Any questions for the morning? LAO? Finance? Any public comment on issues 18 and 19?
Good afternoon, Madam Chair and Senator Monning. Joe Michael for Equality California, and I hope you all don't mind. I will speak quickly to issues 18 and 19 and also backtrack to issue 17.
Not a problem.
Thank you. So just on 18 and 19, we're very much supportive of what DPH is asking here, and hope that they will have the resources that they need to implement those really important policies. And to issue 17, Equality California was the sponsor of AB 959, the Lesbian, Gay, Bisexual, and Transgender Disparities Reduction Act by Assemblymember David Chu. It was the first bill to require collection of data on sexual orientation and gender identity when other demographic data is collected. As I'm sure you are aware, collecting this data is crucial to ensure the health and well-being of the LGBT community, because as we have learned, if we are not counted, we do not count. We are working with experts and other stakeholders to develop the best practices for collecting this data in the context that AB 959 requires, and we look forward to collaborating with DPH and offering assistance as they implement the legislation, and we support DPH having the resources that they need to implement that policy as well. Thank you.
Thank you very much. Appreciate that. Thank you very much for your testimony today. Appreciate it. As we close out, Senator Monning, of our first hearing, any questions or comments?
No, thank you. Nice job.
Thank you very much, LAO and Finance, and to committee staff, and Sub 3 hearing stands adjourned.